Good afternoon, everyone. I am Dr. Pranita Sahay, and I'll be discussing about a topic of perforated corneal ulcer. So, perforated corneal ulcer is an ocular emergency that needs. Okay. Yeah. So perforated corneal ulcer is an ocular emergency that needs to be dealt with urgently with surgical management for optimal outcomes. The etiology in the most common cause being infective keratitis and others being neurotrophic ulcers and PUK are the common causes that can lead to corneal perforations. Now the management is targeted based on the size and location of the ulcer. The treatment has to be modified. For small ulcers, a corneal gluing can be done. For intermediate, a patch graft is needed, while for large ulcers, therapeutic keratoplasty is often needed. Now, during COVID pandemic, we faced a lot of challenges, especially in management of patients of perforated corneal ulcers, because firstly, they had a delayed presentation, the OT protocols were in place, there was lack of donor cornea tissues, and difficulty in the frequent follow-up of patients, wherein different modalities were more commonly tried at that time compared to keratoplasty in these patients' management. So I'll do a case-based presentation here. This is the first patient who's an 18-year-old female who came to me during the first COVID pandemic, first lockdown. She had recurrent episodes of redness and watering, had a course of ATT taken for pulmonary tuberculosis 1 year back, and now she had a conjunctival ulcer. She was a diagnosed case of flectanular keratoconjunctivitis. The look of it looked infectious, but scraping of the conjunctival ulcer was negative, hence we considered that it was a large conjunctival flectin. Started her on steroids. She showed good response. The conjunctival ulcer started to heal, but she developed a PUK by day 3. And again, she was lost to follow-up, and day 12, she developed a peripheral corneal perforation with uveal tissue prolapse despite of topical steroid therapy. Now, we had a patient with a size of perforation being 3 into 2.5. Location was peripheral, there was uveal tissue prolapse. Vision was 6/9. Now, the options were either go for corneal gluing or patch graft. Now, while gluing could be easily done, it was easily available, cost effective, but the stability of glue in peripheral perforation is always a doubt because it does not adhere well to the scleral tissue. Also, the stability in a perforation which is nearly 3 mm is also questionable. So corneal patch graft could have been a better option, but lack of tissue availability, we planned the patient for a tenon patch graft. This is a short surgical video where we can see so we can see that the patient has been taken under peribulbar block. The size of the perforation was measured. A 20% oversize was marked on the supratemporal conjunctival area, and subconjunctival xyloedry was injected. A linear peritomy was done, and subconjunctival tissue dissection was carefully done, following which the tenon tissue was harvested. Following this, the site of harvest was closed by mechanical apposition. There were no sutures applied, no glue, and in the post-op period, we found that it did close well with just the manual apposition. After this, a side port entry was made and pilocarpine and air was injected. However, the uveal tissue, since the perforation must have been there for a couple of days, it did not reposit, and hence a Sinskey hook was used to gently reposit it back without damaging either the iris or the lens, as the patient was phakic and had a clear lens. A localized cushion of OVD was given to avoid adhesion of the iris to the patch graft, tenon patch that would be put. A localized peritomy was also done, and conjunctival tissue was resected out so as to avoid any surrounding inflammation, as the conjunctival ulcer was still there. Also, the bleeders were cauterized. A 360-degree tunnel was made at the site where we had removed the tissue at the site of the defect, following which the tenon patch was sutured with 10-0 monofilament suture. Interrupted sutures were put. Also, an augmentation with cyanoacrylate glue was done at the edges, as leak with tenon patch graft is something that we commonly see in the post-op period that leads to shallow AC wound leaks. To avoid that complication, we put cyanoacrylate at the edges. These are the post-operative pictures. 3 months, the patient had a well-integrated graft, although there was a focal adhesion of the iris there, but there was no uveitis, no inflammation. Vision was 6/9, improving to 6/6. Now, this is another case. Here, this was a 14-year-old male who had multiple surgeries, VR surgery, squint surgery, re-VR, SOR, and finally ended up in a neurotrophic ulcer. Now, the patient was medically managed initially. However, he ended up with a small central perforation. Now, the site of the perforation was central, perf size was less than 1 millimeter. Hence, we went for a corneal gluing. This is a video that we show, wherein we show that even a cyanoacrylate glue application can be done on the slit lamp in an OPD without waiting for an OT availability, especially in cases where your anterior chamber is formed. After topical anesthesia application, we gently applied the speculum. To avoid a collapse of the anterior chamber, the application of the speculum has to be extremely gentle. The surface was dried, the surrounding epithelium was tried to be debrided with the help of this Merocil sponge, and the site of perforation, we gently apply with a 30 gauge needle. We apply a small drop of glue and then wait for 10 to 20 seconds for it to dry. We see that the first drop is applied, and since it was looking a little thin, I reapplied another drop. And at this time, we have to be careful that we don't want a mount formation, because we need to apply a BCL at the end of the process. If there's a mount formation, the BCL is not going to stay, and then the process is of no use. And after this dries, the BCL is applied and the speculum can be removed. Now, this is a third case. Again, a patient, a 45-year-old male, uncontrolled diabetic, was never aware of his blood sugar status. He came with pain, redness, discharge, and diminution of vision for 10 days in the right eye. He had a perforated corneal ulcer, vision of 6/9 because the perforation was peripheral, infiltrates peripheral, central cornea clear. Now, this is a dicey situation. You know, whatever you're going to do with the management of this patient, vision is going to fall, and that is what you need to explain to the patient preoperatively. So now here the location is peripheral, size perforation 2.5 millimeter, uveal tissue prolapse, and surrounding infiltrate. Now, in the first case, we saw that the peripheral perforation, a tenon patch could be done, but here in the presence of peripheral infiltrates, a tenon patch could not be done. Hence, we went for a corneal patch graft in this patient, and as you can see, at 1 month, the graft also cleared up. There were no infiltrates. Uveal tissue the uveal tissue although had to be excised, so the pupil was not circular, but the patient had an uncorrected visual acuity of 6/18 even with this procedure that was done. Now, this is the fourth patient. This is a 5-month-old female who has a keratomalacia sequelae due to biliary atresia. That was the cause for vitamin A deficiency. She had a corneal perforation with melting and a flat anterior chamber. Hence, considering the large size and the peripheral location and associated melting, a tectonic PK was planned for this patient. So in these patients, what we need to do is remove the host corneal button and ensure that you have removed all the melted cornea. Since the horizontal diameter of the melt was nearly around 8 millimeter, we had to excise around 8.5 millimeter. And after removing the host cornea, a repeat measurement is always essential in these patients before we punch the donor cut, because in flat anterior chambers and perforations, your initial measurements may be fallacious. If this was again a patient operated during COVID times where tissue availability was an issue, hence a glycerin preserved cornea had to be used. So the poor quality cornea, that is not what you really want to use in your patients, but in dire situation, maintaining the anterior segment integrity is probably the first priority, and hence we went on with using this tissue and had a well-formed anterior chamber, and the patient was registered for optical keratoplasty later. So with this presentation, what I wanted to say is that every case of perforated corneal ulcer is different, and a case-based approach is necessary for the best outcomes. There are various treatment options available. The location and size of perforation and the state of surrounding cornea ultimately determines the surgical procedure that you have to opt for your patient. Thank you.
Very nice presentation, Pranita. I have not tried Tina's patch guard, but just wanted to ask whether in infected perforated ulcers, would you try
So infected perforated ulcer, first of all, in presence of infection, suturing the tenon graft itself is a difficult thing. People have tried it in the presence of infection where they have sutured it beyond the site of infiltrate and have shown good results. But personally, even I haven't done it in infected patients, so I really cannot comment upon that.
Yeah.
Beyond.
If required.
Yes.
But one thing I wanted to ask is that whatever you did was you reposited the iris. Is it wise to be in all cases? Because you tried to
No, sir. I excised the iris. The iris was excised. I was creating a tunnel all around in the cornea. Oh, in the first case, yes, because there was no infection in that patient, and it was a 1-day-old perforation that the patient was saying, and it looked healthy intra-op. That is why I reposited.
I mean,
Yes.
if the iris is good looking, means no
Healthy.
atrophy, no necrosis, we can reposit in some of the cases.
Yeah, we placed the BCL at the end of the procedure. That was not shown in the video. Yeah.
And what was
And the
the
Tenon patch also, in the end, the BCL was put. Yes.
How was the management after that vitamin A deficiency patient? How was
Yes,
graft
so
survival?
so the graft ultimately did fail. It became an opaque graft. The patient was in pediatric surgery for multiple interventions. Finally, did not turn up for the optical keratoplasty. I saw the patient for 6 months, around 6 to 8 months another. At least I didn't go into phthisis and did not develop glaucoma. The pressures were normal.
Means graft,
Yeah.
means graft was
Graft-
white, but
It was taken up well. Yeah, there was no melt, there was no infection.
Okay, that's good. Yeah. Thanks. Thank you.